We're going to do an overview of the HPA axis. And the HPA axis stands for hypothalamic pituitary adrenal. This is a very large neuroendocrine loop using the hypothalamus and the pituitary. And this will function with the adrenal cortex. But we'll also see that there's a lot of other pieces, like the adrenal medulla. So that'll be the first thing. We'll talk about the general anatomy and physiology, go over the microscopic anatomy because it's important for you to understand the cell types in each division or zone. And we'll talk about the main products of each of those layers of zones. Either they're catecholamines, cortisol, androgen, or aldosterone. Each of them is going to have a very interesting input pathway. They're all different. So when we learn the HPA axis, that will mainly have the control of cortisol. So we're going to go through things like that. So cortisol is related to the HPA axis. And then to tie everything together, we'll talk about how either deficiencies or excesses of certain hormones produce clinical symptoms that you'll see again in pathology. So this is an important section and something that you'll have to know for your boards and for the rest of your career. So going just quickly with the anatomy, there are two adrenal glands. They are located in a suprarenal position. So supra means above. They sit atop the kidneys. They are not a part of the kidneys. They are just housed here. So in the same way the parathyroid glands are embedded within the thyroid, there are two adrenal glands, one per each kidney. Most individuals have two kidneys. If somebody is born with just one kidney, the remaining kidney goes through hypertrophy and hyperplasia until it takes on the size and function of both kidneys. But in that case, there would just be one adrenal gland. But as we've seen, adrenal or endocrine glands can undergo hypertrophy as well to increase their function. Just a quick little note for anatomy. The aorta, so if we're looking at this guy, the aorta would come off of the heart, the left side of the heart, and the aorta runs all the way down unimpeded until it gets to the level of the renal arteries, which is what you see right here. You see aorta to renal arteries. And you'll notice that this is pretty much a 90-degree right angle change in blood velocity and blood direction. What that means is there's going to be more turbulent flow, so the blood swirls when it gets to locations like that, in the same way a jet boat would swirl at the bottom of Niagara Falls. And what that means for the wall of these vessels is that they're likely to become damaged. So you'll see cases where blood pressure goes really high in different disease states like hypertension, and hypertension is something that goes along also with diabetes. And those disorders involve damage to the kidneys, and it really just has to do with the anatomy and then the resulting shift in blood flow. And then we have the vena cavas draining everything below the diaphragm is the inferior vena cava, and then the superior vena cava drains everything above the diaphragm. So these are the renal veins, and those drain the kidneys. So blood goes into the kidneys and becomes filtered, as we'll see in the next couple of chapters. And in some cases, when there's kidney damage, we can have some alterations to the adrenal glands, but that's really just because of one of the products, that aldosterone. So there's two adrenal glands. This is a picture where everything now is labeled, so we start to see the physical vascularization going to the adrenal glands themselves. So you'll see these words, suprarenal, so that's why we pointed that out, superior suprarenal arteries, left suprarenal gland. So that is in association with these adrenal glands. So we have everything written out here so that you can label pictures if you're asked to do so on the exam. And not only do we have two adrenal glands, one per each kidney, so we have a right and left suprarenal gland, but you'll see that when you cut open these glands, there's two specific areas. There's the cortex, so when you'll see adrenocortico, so ACTH, adrenocorticotropic hormone, that is referring to, see, AC adreno, meaning adrenal, and then C is for cortex. And we know trophic hormones are things that are made by the pituitary. So ACTH binds to cells on the adrenal cortex. And remember, cortex is the Latin word for bark. It's like the bark of a tree covers a tree. So the cortex is the outermost covering, where a medulla, so the medulla is on the inside, and the medulla is the region that is not going to be associated with ACTH. Instead, it has a direct connection with the sympathetic nervous system. So this is going to involve sympathetic nerves and the release of acetylcholine, all the things that you learned in Physiology 1. So two separate sections. The cortex will have 3 distinct layers within it, and the medulla contains its own specific types of cells called chromaffin cells. And we've already talked about ECL cells, enterochromaffin-like cells. So if you forgot, those are cells in the intestinal regions that look like chromaffin cells but are not. Chromaffin cells are very important in the sympathetic nervous response and general sympathetic exercise circulating norepinephrine. So here are the different layers you should know, and not only should you know what they look like and where they are, but you should also know what's made by each region. So we're going in this right now. The outermost region, the zona glomerulosa, that makes aldosterone. And aldosterone is our sodium-sparing hormone that is released in times when we have low blood pressure. And it's also part of the renin-angiotensin-aldosterone system, which is going to involve the kidneys and antidiuretic hormone. And antidiuretic hormone is our water-sparing hormone. So ADH is released when we can't spare to lose any more water. So when those things act together, and you probably know where sodium goes, water follows. When aldosterone and ADH are released, it causes more water to be retained in the vasculature, which will help to restore the blood pressure to homeostatic levels when everything is working appropriately. So zona glomerulosa is associated with aldosterone, which is considered a mineralocorticoid. So that is involved with blood pressure regulation. Then we have our zona fasciculata and zona reticularis, and these are areas associated with the production of our steroid hormones like cortisol, which is a glucocorticoid, and then androgens. And as we've talked about in the past, females and males have androgens. Females generally, depending on the genetic conformation, don't have testes. Sometimes they do. If you take developmental biology, you talk all about that. But there's usually inactivating hormones that allow them not to be active. However, in women without testes, they still have androgen production, and it has to do with these areas that produce a specific substance we'll talk about called DHEA. That is an active androgen that's expressed by the adrenals in males and females. And all those layers, these are all cortical layers. Then the medulla, the innermost region, that is the chromaffin region with the chromaffin cells. And chromaffin cells, as we'll see, are TH positive, meaning they can cause the production of catecholamines because they have the cat. And the catecholamines are dopamine, epinephrine, and norepinephrine. And that's the enzyme that helps create them. All right, so those are our different layers. And then if we look histologically, we can see in a stain a very distinct cortical region. We see our 3 different distinct layers. We see a blood vessel that will help to collect the different products, and we have more cortical layers. So 3 distinct layers. Again, here's a nice stain showing you your zona glomerulosa and the aldosterone that's created there. The zona fasciculata, which is associated with the production of our glucocorticoids, our cortisol, and the zona reticularis, which is DHEAS. The innermost medullary region, so the medulla, 10 to 20% of the cells of the adrenal gland are chromaffin cells, which help manufacture epinephrine and norepinephrine through the pathway that we first introduced in the introductory endocrine lecture. Okay, so we'll start off with the medulla. Well, this is a very blurry picture. I'm sorry about that. So we'll start off with the medulla. And this is mainly a review because this is stuff that we learned in Anatomy and Physiology 1 or Advanced Physiology 1. There are two ganglion chain neurons in the sympathetic nervous system, and you might remember that if we're looking at a cord, so that's a brain and cerebellum brainstem, here's a spinal cord, and we know that parasympathetic involves nerves coming from the cranial nerves and the sacral portions, whereas the sympathetic nerves derive from T1 to L2. And those nerves come off and they usually synapse at this sympathetic chain ganglia, or they can go off to a specialized ganglia in the tissue, like the celiac ganglion. And then the postganglionic neuron picks up from that ganglia chain and then goes out to an organ. So that's a two neuron chain involving the release of acetylcholine, which binds to nicotinic receptors on the postganglionic neuron. And those nicotinic receptors, they bind acetylcholine. So we have a positive excitatory reaction, and that drives typically the fusion and release, vesicular fusion and release of norepinephrine by the postganglionic neuron. This is true for pretty much all of these nerves in the sympathetic nervous system. But as you know, there's always going to be exceptions to every rule, including physiology and other types of science. There is one nerve that is called a modified postganglionic neuron, or one specific cell, and it's these guys. It's the chromaffin-like cells. So here you see a preganglionic neuron deriving from the cord, as we see all of these sympathetic nerves do, meaning it still is going to be activated. It's still going to release acetylcholine instead of activating a secondary neuron to have an action potential and release norepinephrine. That acetylcholine binds to nicotinic receptors on a chromaffin cell. And in response to that, the chromaffin cell, through the tyrosine hydroxylase pathway, can manufacture circulating catecholamines to enhance and prolong the sympathetic response. So those would either be epinephrine and norepinephrine. So this is a modified postganglionic neuron. So we have our preganglionic, and obviously one cell is not a neuron, so we call it a modified postganglionic neuron. All right, so acetylcholine, nicotinic receptors. We have this pathway activated. We get methylation, and then we get the production of the catecholamines. All right, so this is what you see again here. So from T8 to L1, we have sympathetic nerves that can coalesce together in the sympathetic trunk, come out the ventral root through the thoracic splachnic nerves, and innervate these chromaffin cells. So the chromaffin cells, again, they lie in the adrenal medulla or medulla, whichever you like to say, as long as you say it with confidence. And they can produce catecholamines because they are TH positive. They can allow tyrosine to be modified by tyrosine hydroxylase, then into dopa, then into dopamine, then epinephrine and norepinephrine. So this is how we drive a prolonged sympathetic response. So they are modified postganglionic neurons. They're not technically neurons, but they do the job of what a postganglionic neuron would do. And then this epinephrine and norepinephrine enters the bloodstream and can circulate to prolong a sympathetic response. So if we don't have the creation of these catecholamines by the adrenal medulla, then the sympathetic response just lasts a couple of seconds. So if you think about being startled, you have an initial reaction caused by the release of norepinephrine onto different organs surfaces, and those organs respond in whatever way that organ is meant to respond to. They all have a different job. But then it will diffuse away as those catecholamines are broken down by their requisite enzymes. When this system is activated, we have the promoted or prolonged creation of epinephrine and norepinephrine. So this can circulate in the blood and continue to bind to receptor sites on the organs so that we can continue a sympathetic response. Okay. This is a very high, sorry, I'm doing two things at once. I clearly can't do that. This is a very high resolution image of chromaffin cells. So here is the chromaffin cells. Here's cells of the zona reticularis. So they do stain differently. So we can see the differences between these layers as we're looking. And zona reticularis is the first layer as we go outwards towards the center. Here's a big medullary vein, called that because it's coming to drain the medulla. And then we have a sinusoid, which, as you may have learned, or if not, now you know it's the leakiest type of capillary in the body. So that allows free exchange of substances without the necessity for a lot of diffusion because they're so very leaky. So we have a sinusoidal capillary, we have a medullary vein, we have the chromaffin cells, TH positive, I'll keep saying that, it's important, they're TH positive. They make catecholamines, and those can be drained right up through the medullary vein and then brought up very quickly to the vena cavas to get right to the heart. So it's a pretty quick reaction, and this happens almost immediately. Okay, so this is it tying everything together that I just mentioned with you. This lady looks really sad that we're looking at her adrenal medulla, but the adrenal cortex is going to be involved with this HPA axis. The adrenal medulla, that is going to function as a modified postganglionic neuron. Again, here's your picture, preganglionic sympathetic nerve, releasing acetylcholine, binding to the nicotinic receptors, and then epinephrine, norepinephrine are produced to go out to the target tissues. And I hope you remember what type of receptor norepinephrine binds to in target tissues. Do you remember? Do you? It is the alpha and or beta receptors. All right. 80% of chromaffin cells make norepinephrine, 20% make norepinephrine. These can both bind to alpha and beta receptors and cause the same physiologic response. Nor comes from NOR, meaning it just differs by one functional group. So it's really just one methyl group. All right. So catecholamine release is something that's released when there is not just psychological pain, trauma, anxiety, but it definitely is, right? So that's one way that we can trigger a sympathetic response is psychological pain. And then there's physiologic stress. So those are anything that would disrupt physiologic homeostasis. So that could be a drop in blood pressure. So if your blood pressure goes down, you want your heart rate to go up. So that will stimulate a sympathetic response. When your blood sugar goes down, so fasting states trigger this. We've said that a lot. Low body temperature. Those are things that trigger the message to the hypothalamus that its thermostat control of homeostasis is off. So physiologic stress, psychological stress triggers to the hypothalamus, that's our integration center, so that we then have an outflow pathway through the sympathetic nervous system. All right, so that can either go through the typical pathway we've talked about, acetylcholine's released, binding to nicotinic receptors on the post-ganglionic neurons, which release norepinephrine, which act on target cells by binding to alpha and beta receptors. Or we can have the associated activity of, instead of it going to a ganglion, we get acetylcholine release binding to chromaffin cells, which in turn spit out epinephrine or norepinephrine. All right, and so see here we have our tyrosine hydroxylase. That is the enzyme that is necessary to create catecholamines. Dopaminergic neurons contain TH as an enzyme positive. That's something that I look at a lot in the lab, is TH positive cells, and chromaffin cells are TH positive. Okay, so I went over this initially in the introductory lecture to endocrine. It's just called Intro to Endocrine. This is the full tyrosine hydroxylase pathway. Knowing this makes me really happy if you know this full pathway. It helps to explain a lot of medicine, the way that tyrosine residues are incorporated into making these catecholamine-like substances. The type of medicine that this helps you understand is treatment for Parkinson's disease. As I mentioned in the first lecture, dopamine is too large of a neurotransmitter to make it across the blood-brain barrier. So when given systemically, it will cause sympathetic discharge at the tissue level, but it doesn't cause any differences in activity in the level of the brain where you might need it. So what they give to patients is a modified type of this called L-DOPA, and L-DOPA finds TH positive cells where it binds, enters the cell, and then TH modifies it into dopamine. And then we have norepinephrine, epinephrine. So here again, this is our no R group, and then we have an R group that's added, a functional group. All right, so acetylcholine stimulates the exocytosis of the chromaffin granules, and whenever a cell contains granules, as you probably learned in micro, granules are just vesicles filled with things, so whatever is inside of them can be released. For chromaffin cells, it's going to be eventually epinephrine or norepinephrine. Beautiful. So that's your medulla. These are the actions of catecholamines at adrenergic receptors. And let me just explain this word really quickly. Adrenergic comes from the word adrenaline. So the old school name, for epinephrine was, and still is used in layman's terms quite often, is adrenaline. So adrenergic means adrenaline-like receptors or adrenaline-binding receptors. So there was adrenaline and then there was noradrenaline. So now we use the terminology epinephrine and norepinephrine, but we still use the term adrenergic receptors just to make life difficult for everybody. So here's the adrenergic receptors. Remember my rule for even and odd. If it's an odd number, it's an excitatory receptor. So odd, odd, odd. If it's an even number, it's an inhibitory receptor. So when you have binding of norepinephrine to an odd receptor, it's generally causing the action of that tissue. So the cell becomes depolarized, becomes more positive, and it's going to do things like increase contraction. This IP3 pathway I go over in the introductory lecture, and the important part of this pathway is that IP3, it liberates intrasarcoplasmic reticular stores of calcium. Calcium then drives up the charge of the cell, making it depolarized and then causing the exocytosis of the associated neurotransmitter. Instead, when you see an even number like alpha-2 receptors, you see them mainly on muscle cells, like smooth muscle cells, especially in the vasculature. You see them on presynaptic nervous terminals. You see them on beta cells in the pancreas, and they inhibit norepi release. They inhibit insulin release. Beta 1, you see those on the heart. Predominantly, they're also all over the place. Everything here is all over the place. This is just an example. So they're predominantly in the heart. They increase the utilization of cyclic AMP, so it increases cardiac output, which is heart rate times stroke volume. So how many times a minute the heart beats times how much blood is ejected per each heartbeat, which is usually, in a healthy heart, 15 milliliters or 3 tablespoons of blood. All right. Beta 2 receptors are interesting, and depending on their location on the synapse, they can function in different ways. They do cause an increase of cyclic AMP activity, and depending upon where they are, they can do different things. You'll find beta 2 receptors on the liver, smooth muscle, definitely the bronchioles. They're in really high concentration there, as well as in the uterus. So when beta 2 is active in the liver, it increases glucose output. So it has an increasing activity there. However, when you bind to beta 2 receptors on the bronchioles or blood vessels, you get a relaxation effect. Same thing with the uterus. Beta 2 receptors can be targeted with a drug that's now not legal in the United States, but it's used in other countries. It's called ridodrine, and it's used to inhibit premature labor and contractions. All right, then we've got finally beta 3 receptors. They increase cyclic AMP, so this, we can increase it, and then I'll explain to you what presynaptic versus postsynaptic means when I have a whiteboard in front of me. Okay, liver cells, adipose tissue, again, increase glucose output by the liver, increases breakdown of fat, so typical excitatory types of sympathetic reactions. Okay, so those are our different receptors. Please know them. I'm going to ask you a lot of questions about them, just so you're not surprised, because that's really important. And that helps tie together the way that your treatment plans work and how to understand what medications your patients are taking are doing to the resulting physiology. Okay, so this is actually going through some of this now. Oh, great. So alpha-1 receptors, the reason that they are considered excitatory receptors and alpha-2 receptors are inhibitory type receptors are because of the location of them with regards to the plasma or the synaptic membrane. Go away. I want you to leave. I just got rid of you, Phil. Don't tell anybody I did that. Okay. Don't tell. It's a secret. All right, so what do we have? We have a typical postsynaptic receptor here, meaning that neurotransmitter would traverse the synapse, it would bind here, there'd be some sort of resulting cascade, which would eventually allow the entry of positive ions, and that cell would become depolarized, and then everything is great. So that's a typical response that we would expect, right? Okay, so now we get into what I spend all of my time thinking about, and it's these things called autoreceptors. Auto means self, right? Autoreceptors. And autoreceptors are inhibitory receptors. So the way that they're meant to function is that when something is released into the synapse, and there's so much of that substance released, that whenever it binds to a receptor, it's going to pop right off again. These are millisecond reactions because these are globular proteins that are involved. When there's an excess of that neurotransmitter, so we had a whole bunch of release of something like norepinephrine, when there's so much flooding the synapse, some is bound to bind to this presynaptic receptor. This is going to signal to this presynaptic cell that it's released more than enough of that hormone, that neurohormone, that neurotransmitter. So it's a message to shut off extra production and then definitely extra vesicular fusing and docking so that we have exocytosis into the membrane. So autoreceptors are inhibitory receptors, and that helps to explain the rule why your positive receptors Those are excitatory. They're postsynaptic and they function in a typical expected way. Even numbered receptors are presynaptic and they function as a presynaptic shutoff, an autoreceptor. They're a self-receptor to regulate release of the neurotransmitter. Okay, I hope that makes sense. Okay, so just like everything else in the body, as I've mentioned, you have all types of hormones all over the place, and they do all types of weird things. So when testosterone binds to hair cells, it increases hair growth and hair thickness. When testosterone binds to Leydig cells, it increases the production of more testosterone, or in Sertoli cells, it increases spermatogenesis. So it can have different activity in each tissue. So we've already said that the most common second messenger system in the body, really, is this adenylate cyclase pathway, where adenylyl cyclase is an embedded protein in the membrane, which helps to catalyze the reaction of cyclic AMP. And increased levels of cyclic AMP increase cell activity. So things like contraction. This is different. We'll talk about that in a second. This is not a numbered beta cell receptor, it's just a beta. So it's different with 1 and 2. Alpha 1 receptors, they utilize the second most common second messenger system, the phospholipase C pathway that I've already went over. When this phospholipase C is activated as part of this process, we get this really big protein, this PIP, which then dissociates into 2 separate pieces. One of them is DAG, which is a membrane-bound protein, meaning it just kind of hangs out there and it says, "Dag, I'm sad, I can't leave the membrane." But IP3, that has the important job. Hooray, it's the star. It's going to go down and open up these calcium channels so they're calcium like gated channels on the sarcoplasmic reticulum, which houses stored calcium. So calcium binds to let calcium out. There's lots of calcium. The calcium not only drives up the charge of the cell, but it also predicts the strength of contraction. If anyone ever asks you what is the predominant decider for the strength of contraction, especially in cardiac muscles, it's the amount of extracellular calcium. The more calcium there is, the harder the contraction. So it drives up the charge and it also promotes strong contraction. Okay, this again is a review of what we would see in a typical sympathetic response. We went over all of these things in the first part of anatomy and physiology. So you're going to have to create fuel sources for the body. So instead of storing glucose and fat cells, we're going to need to break it down. We're going to have to break down glycogen. We're going to have to increase insulin secretion in some cases because we are going to need glucose to enter some cells that might need it, like muscle cells. We're going to have lots of potassium uptake. We're going to have the breakdown of free fatty acids. And the places that we don't need to do anything important with a stress response are going to decrease. So we're going to decrease like the storage smooth muscle effects of the urinary tissues, and we're also going to decrease the activity in the gastrointestinal tract, as we learned in the GI chapter, because remember, 40% of splanchnic the splanchnic circulation is taking up 40% of cardiac output in rest and digest symptoms. So when you're just hanging out and resting, not stressed or exercising, 40% of that blood flow is going to support the splanchnic circulation. So intestines, liver, that's all splanchnic. We don't need that diversion when you have to exercise or when you're in fear for your life or you're in a sympathetic, just general stress response. That needs to be diverted to the brain and then to the muscles that are going to utilize it. So everything here, and also the associated receptor subtypes are listed here too for you to peruse, which I hope you do. The other thing that helps tie everything together is you'll see these beta 2 here. So beta 2 receptors in all places but the heart, they are presynaptic. So in the bronchioles, they function as these inhibitory autoreceptors. So even though in exercise everything else is going up, like heart rate, blood pressure, like glucose utilization, or not utilization, physical storage is going down, but glucose availability, sorry, that was the word that I was looking for. We have to have the relaxation of the bronchial smooth muscle. If the bronchial smooth muscle contracted, we wouldn't have airflow. So that would be counterintuitive, and then that causes respiratory distress because the heart rate goes up, and to support the increased heart rate with exercise, you need to have an associated relaxation of the bronchioles. So that is actually why people with respiratory disorders shouldn't take beta blockers. Most beta blockers block beta 1 and beta 2 receptors, so they're non-specific. So you'll get a blocking of increased heart function at the level of the myocardium, but you'll block inhibitory beta 2 receptors in the lungs, which means you block dilation and relaxation. So that promotes bronchoconstriction and respiratory distress. So those are things that are contraindicated. Contra means against. It's against advice. Okay, so metabolism is just breakdown of catecholamines. So you can't have catecholamines circulating forever. You would die from that. It's called the exhaustive phase. And it kicks in after a couple of days. So a really long sympathetic outflow is fatal. When you think about people who haven't slept, that would be reaching the exhaustive phase. So after, what is it, like 3 to 5 days without REM sleep, that usually leads to death. We'll talk about that more in patho. I don't want to go too far down that rabbit hole because we're almost done. But what I want you to understand for this specific lecture, so I'm going to reel myself in right now. There are 2 large enzymes that break down circulating catecholamines in most cases. We have the MAO, which stands for monoamine oxidase, and then we have COMT. So MAO and COMT. The way that MAO technically works is that inside of a nerve terminal, when these things are being manufactured through the tyrosine hydroxylase pathway, when there's excess catecholamines, so if this was excess epinephrine, for example, the way that MAO works, it's associated with the vesicles, and it's an enzyme that's intracellular. And the way that it's supposed to work is that when there's excess intracellular neurotransmitter that don't have room in the vesicles, they're already full, MAO would be right here, MAO. So MAO oxidase, it breaks down the intracellular catecholamines. And there's 2 different types. There's MAO1 and MAO2, and you learn more about them in pharmacology. Right now, I just want you to think MAO, monoamine oxidase. It breaks down those neurotransmitters, so then we can break them down into their component parts, bring them back up to the cell body, and then manufacture things when we need to. COMT is an extracellular, so it's out in the synaptic space, enzyme that helps to break down circulating catecholamines in the synapse that we haven't uptaken into the cell through a reuptake transporter. So we do that a lot. Maybe we don't want to make more from scratch. Maybe we just want to recycle what's in there, and then we can repackage that in a vesicle. So COMT is a big enzyme out here that breaks down catecholamines. For just your little pharmacology tie-in, you've probably heard of MAOIs. MAOIs are monoamine oxidase inhibitors, and they're used to treat things like depression. And the idea is that if there's more associated circulating catecholamines, and there'd be some dopamine on here too, then it has more of a chance to bind to its receptors, and then you feel better. There's also COMT inhibitors. So COMT can be inhibited in the same way. We can block the binding site for the neurotransmitter to be degraded through this process, increasing the level of catecholamines, increasing the amount of binding interactions, and then hopefully increasing mood. These are not just always with prescription. An example of an MAO eye drug is St. John's wort. And St. John's wort is over the counter. It's an herbal medication. 30% of medications that are sold in pharmacies and by prescription are herbal in origin. So it's not special in that. It's special in that it's not FDA regulated and it's available over the counter. One thing I want you to keep in mind when you're thinking about ways to have patients report their medications, think of a way to get them to report any herbal supplements they're taking, vitamins. Those are still medications and they're still going to have interactions with other medications. St. John's wort has an interaction with pretty much every single thing on the market. So just make sure you kind of keep that in mind, please, for life. Okay. To finish up the medulla, the little piece of pathophysiology is a specific type of tumor, and it is called a Pheochromocytoma. So this is an interesting growth, and we can tell by looking at this that it's actually a benign growth, and we can tell that because it's a really well circumscribed growth. And as we keep mentioning, it's really common to have benign growths in endocrine tissue. And hopefully you know the rule now that whenever there is an endocrine growth, so an adenoma, remember adeno means gland or organ, and oma means growth. So an adenoma is just an increased tissue growth on an endocrine gland, usually. Whenever there's an adenoma of endocrine tissue, you're going to have a really strong increase in whatever that cell's job is. So if chromaffin cells' jobs are to make catecholamines, you can guess that in pheochromocytoma, where there's this big benign growth of chromaffin cells in the medulla, there will be a huge increase in catecholamine production. This is not a common disorder in itself. Okay, so this isn't going to be like in 50% of the population. It's a surprising find when it is found. However, when we're looking at the medulla, so if you did a CT scan of somebody with really high blood pressure and you found that one of the adrenal glands was very, very large, you would immediately think pheochromocytoma. It's the most common reason of medulla hyperfunction. So even though in and of itself is a disease overall in the population, it is the most common disease of the adrenal medulla. You will see that the production of norepinephrine is most elevated, so there'll be profound hypertension. So we're talking bottom numbers of like 150 to 200. So it's really, really high. Whatever happens in the system is opposite in the brain. So hypertension means that blood vessels are really small. They're very constricted. That means that the cerebral blood vessels are going to dilate in response to that to restore their own blood supply. Your brain is encased within the dura and then also within a skull. So it doesn't have anywhere to go. So that's essentially what a headache is. It's the swelling of these cerebral blood vessels impinging upon the cerebral tissue, then causing pain. Also, when the blood pressure gets that high, you get into a very sympathetic outflow, but you also see that this is just generally circulating and they're constantly in sympathetic. So they'll be sweating, very high heart rate leading to anxiety responses, especially to those with a history of anxiety responses, ventricular palpitations, which is when the ventricles essentially feel like they're beating out of the chest and they skip a beat because they overfill and then underfill. And as you'll talk about with Dr. Hechtel, that has to do with smoothing out the systemic blood pressure over time. And then when the heart is beating very long, very strongly for a long time, you eventually shift from aerobic, so using oxygen, to anaerobic respiration. And that generates the presence of lactic acid. And whenever lactic acid's around, you're going to have soreness, you're going to feel pain. That's what angina is. It's the shifting of aerobic to anaerobic metabolism and then the creation of lactic acid. Lactic acid will drive down the pH in that region, which is going to further increase the muscle contraction in that area, which leads to pain. So it's really important that this is removed. And once it's removed, so we want to remove this. And once it's removed, it's really good prognosis for the patient. It just has to be located appropriately. So you would need a really high level of hypertension. Patients also report orthostatic hypertension, which is blood pressure changes associated with postural changes. So when you're standing, you have your blood pooling in your lower extremities, whereas when you're sitting or laying down, let's make this person lay down. Now we have blood pressure pooling here in the general trunk area and towards the back of the body. So when you stand, there's going to be an immediate gravitational shift of blood flow to the lower extremities. And because of the myogenic mechanism, remember, muscle, when it's stretched, responds by contracting, right? So when that gravitational kind of pull happens, all of these smooth muscle cells will be stretched, which will contract to increase the velocity of blood flow upwards and then regulate blood pressure so that you don't pass out. Orthostatic hypertension is when people feel dizzy, have visual changes, or can have syncope, which is science for fainting, when they go from a seated to standing or laying to standing position. So that's Pheochromocytoma, most common medullary disorder. In the next lecture, we'll go through the regions of the cortex. Thank you for listening, and I'll talk to you then.